what do we know about semaglutide in type 1 diabetes? I thought that was only for type 2.
Yeah, you shouldn't use GLP-1s in type 1 diabetes. You have to give them insulin because otherwise they die.
That's what the guidelines say.
Yeah, that's what the guidelines say. And we should follow the guidelines because that's what's best for the patient.
100%. Well, I think that's enough for today.
All right.
I guess in the past couple of years, there's been some really interesting developments there and actually some advances in what seems to be pretty outdated care that type 1 diabetics have been receiving. But this study actually was in, I believe, New England Journal of Medicine very recently. What do we know about semaglutide in type 1 diabetes? I thought that was only for type 2.
Yeah, you shouldn't use GLP-1s in type 1 diabetes. You have to give them insulin because otherwise they die.
That's what the guidelines say.
Yeah, that's what the guidelines say. And we should follow the guidelines because that's what's best for the patient.
100%. Well, I think that's enough for today.
All right. More insulin for everyone. But in all reality, imagine a study on type 1 diabetes where they use, I believe, no insulin, zero insulin.
Yeah, they may have used a bit of insulin, but I think many of the patients remained insulin-free.
Yep.
I actually posted about this one when it first came out on Instagram, so that'll probably more detail covered there if you want to check that out. But basically, these people were very soon after their type 1 diagnosis. So within a month of type 1 diagnosis, they were started on a microdose of semaglutide. It was 0.125 milligrams, which you can't get commercially. We hypothesized whether this was compounded semaglutide they were using, but realistically, they were probably just doing half of the clicks on an Ozempic pen to get a roughly 50% of the starting dose because they wanted to prevent hypoglycemia in these patients.
That certainly could have been. Imagine being a company and having two medications that are the exact same, semaglutide. Let's just call it for what it is, Ozempic and Wegovy. And for Ozempic, you let people start at a lower dose, and you do not for Wegovy. And you also happen to kind of have the same exact device as something like a Trulicity from a different company. So I don't know how all that works within big pharma. And both companies have great medications, but it is interesting to see how they would take something that is potentially very useful and then do away with it. So
it's like when your computer updates and you lose a feature that was very useful, because you could do micro titrations with the Ozempic pens, whereas with Wegovy now, you get what you get. That's basically the way it's going.
Yep. Very common to see significant side effects on the starting dose of Wegovy, but no need for us to rant on our soapbox on that for a long period of time. The study that we're talking about also compared to other groups that were receiving standard of care. And one of the studies was looking at imatinib. Another one was looking at a monoclonal antibody. And that's among the, type 1 diabetes is considered an autoimmune disease. And some people like testing for antibodies, some people don't. Maybe we touch base on that too. What should you test for autoantibodies? Should you try to figure out what type of type 1 diabetes? Is it MODY? Is it LADA? Perhaps not even worrying about that if it's early onset. But in these studies, they looked at the initiation of these therapies and the percentage of glycosylated hemoglobin. That's just hemoglobin A1C.
Yeah, and they were starting off at a pretty extreme A1C level. So you would expect someone to be having symptoms at this level. I mean, they're between 11.5 and 12% A1C. For reference, someone who is non-diabetic, good metabolic health, they're going to be between probably 4.8 and 5.6 is considered normal. If you see someone at 5.5, 5.6, you're probably looking a little bit closer to see, is this person going to tip over into prediabetes in the coming years, kind of looking at their metabolic picture, but very rapidly. So it looks like within 6 months, they had sort of caught up. Can't exactly say they caught up because they started different time frames after diagnosis, but by 7 months, they were doing far better than any of these two previous trials. Again, small cohort of patients. I think it was 10 patients in total. And I believe that their hemoglobin A1C normalized very in a pre-diabetic range, not in a true diabetic range by the end of the study.
Yeah, that's correct. And like we mentioned, many of them remained completely insulin free because red blood cells do have a lifespan of 3 months, maybe a touch longer or shorter, depending on the person. 3 months after starting the semaglutide 0.125, the average A1C had gone from, I believe, over 12 to around 7. So that's considered pretty good control, especially for a type 1 diabetic at higher risk of hypoglycemia. There's a few other takeaways from this. One concept that I believe we discussed on the podcast before is the concept of beta cell preservation. And that can be both beta cell preservation while on therapy and after finishing therapy. The kind of like original beta cell preserver is just insulin itself.
Yeah, and you see that with type 1 diabetics, what they refer to as the honeymoon period. You kind of see it on this graph here, up to about 4 to 5 months. It looked like these patients on the monoclonal antibody with standard of care had some improvement, and then they sort of started deteriorating about that 5-6 month mark, and that's kind of anywhere from 3 to 12 months is your typical honeymoon period. But it looks like you did not see the same honeymoon period. So again, it's a different cohort of patients, so it's not apples to apples. But it was also just you could almost call this a microdose of semaglutide, because the max dose they were titrated up to was 0.5 milligrams, which is almost 5 times less than the maximum prescribed dose of semaglutide. And they have up to 7.2 milligrams in clinical trials, which is kind of wild to think of.
Yeah, it's pretty wild. It's the arms race of GLP-1s, which maybe we'll talk about at a different time. And we have touched base on that before. But yeah, I guess since we're talking about newly diagnosed type 1 diabetics, often they're diagnosed relatively soon after developing the condition, sometimes not. If they have an A1C of 12, they've probably had it for several months at least, because they have to glycolate that hemoglobin in order to get that high. But there is some interesting differences between screening for various comorbidities, for example, diabetic retinopathy and diabetic nephropathy. And those would be things like a retinal exam and screening for proteinuria and kidney function.
Yeah, and we'll talk about what we think are some of the good guidelines that are in place, some things that don't seem to make a lot of sense intuitively, but a lot of times these societies are hesitant to make a screening recommendation if there's not robust data to support it, even if we know intuitively, like, hey, this makes sense, this is probably going to benefit the patient.